Welcome. I'm Dr. Alex, one of the organizers of the 2026 Central Texas Parkinson Symposium. This presentation is one of 9 talks in a series created to inform, support, and empower individuals and families living with Parkinson's disease. You can watch these sessions in any order. Follow what feels most helpful to you. Links to the other talks, along with additional resources and ways to connect, are available in the description below.
Awesome. So I'm Dr. Butt. I'm a movement disorders trained neurologist, and I currently work at Baylor Scott White, Round Rock. So I welcome you all and thank you for coming here. Whether you have been diagnosed with Parkinson's disease, or somebody who is a caregiver for Parkinson's disease, or just here for learning, this is the place to be for understanding and for hope. So I hope you find something good after this talk and it gives you hope. So this is a picture of Dr. Parkinson's, who was a surgeon, and in early 1800s, he wrote this paper about essay on shaking palsy. He was very accurate in his observation, and he talked about 6 cases. 3 of those he personally examined, and 3 he saw or observed on the street of London. Later on, his work was actually appreciated by Charcot, and the disease was named Parkinson's disease. So we still anchor on the clinical exam findings for the diagnosis of Parkinson's disease. Why patients have Parkinson's disease? It's because of this abnormal or misfolding of this protein, which we call alpha-synuclein protein, which is deposited in the middle part of the brain, and it constantly damages those cells, which makes dopamine. Dopamine is a chemical which we need for the movements, which we need for the smooth movements, for tremor control, or for walking, for slow movements, and for faster movements as well. So these are the 4 cardinal symptoms of Parkinson's disease. The one which is required, which everybody with Parkinson's disease is required to have, is what we call bradykinesia. It's a Greek term. Brady means slow, kinesia means movement. So slow movements, which is manifested in their voice, which is manifested in their facial expression, in their walking, in their overall daily task, like how they're getting in and out of the chair, how they're buttoning their shirt, how is their handwriting even. And then they need one of the other 3. The other 3 include resting tremor. Not everybody with Parkinson's disease have a resting tremor, but it's one of these symptoms or sign of Parkinson's disease. And then rigidity and walking difficulty, how they're walking. Are they dragging their feet? Are they taking smaller steps? So once we see these patients, we are like, okay, you meet the criteria for Parkinson's. This is a very old picture, and I like to put it in my talk because it's about the dopamine-making cells and about the loss of dopamine-making cells in substantia nigra. So every time I used to give a talk when I was in training, I would get asked questions on this. So I thought that I would always include it in my talk. Like this is just telling us that the dopamine-making cells are reduced as the disease progresses. And then, as I talked about the alpha-synuclein pathology and the diagnosis of alphas, or the landmark, that this is one of the pathogenesis of of Parkinson's disease, which led us to the testing as well. So how are patients diagnosed with Parkinson's disease? So if you have tremors, if you have slow movements, if you have walking difficulties, you go and see your neurologist. And what your neurologist or a movement disorder specialist does is basically they do your exam. They ask you a lot of things and they do your exam. And then they observe these things over time and they diagnose you with Parkinson's disease there and then, which is at at times very daunting. Like you went to a doctor's appointment and you were just thinking, I'm here for a tremor exam, I'm here for balance exam, and she's diagnosing me with Parkinson's. That's not what I expected. However, this is how we have been diagnosing patients with Parkinson's, and so far, this is the test to diagnose patients with Parkinson's. Every time I diagnose patients, or as a movement disorder specialist, we diagnose patients, the questions arise. Are there any tests that we can do which can help us determine if this is Parkinson's disease or not? Why? Because testing is huge. We rely on tests. However, so there are these two tests for Parkinson's disease. One is called DAT scan, dopamine activator tracer uptake test. What this test does is you give patients iodine. It's a nuclear study test, and you look at the uptake of iodine in the middle part of the brain. In patients with Parkinson's, because of loss of those dopamine-making cells, the uptake is reduced. There is less of those uptake in the dopamine-making cells in Parkinson's disease patients. However, this test early on in the disease is normal. So I see it on my exam, I put patients on medication, and if they respond to it, this is the teller, this is the exam, and this is telling you that this is Parkinson's disease, instead of relying on that test, which eventually, what if it is normal? What if it's false negative? It just brings a lot of confusion. And then there is alpha-synuclein skin biopsy, which I do in my clinic, or most of the movement disorder specialists do in their clinic. It's a punch biopsy. We send out the testing. However, the best thing is to put patients on medication and look at the response from the medication as well. So this is right after you went to the doctor's appointment, you were diagnosed with Parkinson's disease, and they have asked you tons of questions, and then you are just clueless, and you are like, okay, I was diagnosed with Parkinson's disease. This is not what I was expecting. And they always ask you these questions. It's a list of questions, but it talks about the course of Parkinson's disease. What we have learned over years is that the Parkinson's disease has these pre-motor symptoms and motor symptoms. What are pre-motor symptoms? Which means before patients develop the movement symptoms, which I talked about, tremor, the slowness, the stiffness, and the walking difficulties, they had these other symptoms like constipation. Most of you guys have chronic constipation. Not everybody needs to have all the symptoms, but they have constipation. They have what we call REM behavior disorder, where they're talking in their sleep, thrashing in their sleep, yelling in their sleep. Sleep is like really real. Dreams are really real to them. And that's when I ask patients, they're like, but I've always done it. It's nothing new. But that's a course, that's really telling us the course of Parkinson's disease. And most of them have reduced sense of smell or mood issues. And then they develop movement disorders, followed by how patients manifest afterwards with on and off. They are taking medication, they feel on, and then they feel off, and then some of the behavioral or memory issues arise as well. So that was also telling the same thing, that there are prodromal symptoms, and then the movement symptoms, and then followed by the other progressive non-motor symptoms as well. So I'm gonna briefly touch on these three main prodromal or non-motor symptoms. So let's talk about REM behavior disorder, because most of the patients suffer from this, and they really are not aware that this is a big part of Parkinson's disease. So initially it was described by Shenek in 1986. It's been a while. And he talked about 4 elderly men who had this syndrome, which we call REM sleep syndrome. So what is a REM sleep? It's a rapid eye movement sleep. So when we look at their sleep waveform, we attach these EEG leads on their head, which talks about the waveform of their brain. We saw that their eyes were moving, but no other activity. Why? Because they were sleeping. And then We attached the EMG, the muscle leads, to their legs, and we felt that they had no tone in their legs. That's normal. However, in patients who have REM behavior disorder, what happens is that the lower half of the brain doesn't send the signal to the spinal cord to be paralyzed. Big word, but it basically paralyzes your body, so your body is not moving at that time. And we saw that their eyes were moving, but they had a lot of tone in their body as well. This is strongly associated with Parkinson's disease patients. So this brings us to this big question which most of the patients are always asking, or we are asking to ourselves as well as a neurologist. Parkinson's disease, a gut feeling, a gut-brain axis question. So there is this hypothesis, which is what we call Barak hypothesis, which a neuroanatomist in Netherlands, whose name is Barak, he came up with this hypothesis that it really starts in your gut with microbiome changes which happen because of alpha-synuclein pathology. So patients have constipation years before they develop Parkinson's disease symptoms, which then ascends and reach your olfactory lobe and kind of your nasal area, and patients have hyposmia, reduced sense of smell, reaches the lower half of the brain, medulla, which leads to REM behavior disorder. And then it ascends to substantia nigra, or middle part of the brain, which causes the motor symptoms of Parkinson's disease. And then as the disease progresses, it reaches the cortical, or the front part of the brain, and causes more memory issues, hallucinations. It's still a hypothesis, but a lot of research going on it. And we always recommend patients to take probiotics, eat healthy, and that's where it is coming from. So a lot of you guys are aware of the non-motor symptoms, be it behavioral symptoms, be it sleep symptoms, be it autonomic function, dysfunction, which is constipation, drooling, or appetite issues, or sensory issues with reduced sense of smell, posture, pain. So in summary, Parkinson's disease is a multi-system disease. It's not just affecting your movements, it's affecting the whole body. And it's not just a movement disorder, and we don't see these symptoms later in the disease. These are going on as patients are presenting to the clinic. So we do need a comprehensive and an interdisciplinary approach in evaluation and in management of Parkinson's disease. So this brings us to this question of patients presenting to the clinic with these symptoms and getting diagnosed with Parkinson's disease. It's easy. Patients say, it's easy for you to say. It's 45 minutes appointment and you are saying I have Parkinson's disease and you are out of here. So they hear a shock, then followed by fear, what my future entails. And then eventually they kind of get peace, develop some peace with it, start on medication, get better, have the support system in the community, and then they feel a little bit better about what it entails. But then as the disease progresses and they are more in advanced Parkinson's, it brings out this uncertainty about future. I've learned this from my patients, and I always say this, my patients taught me a lot of lessons in this life. And one of them is that it's all about quality of life, not the quantity of life. You and I don't know how we are gonna live or how much are we gonna live. It's all about quality. So focus on quality, and that's where I come in, and that's where I am working with you guys to help with the quality. And I always say, it's not a disease of patient, it's a disease of family, because the caregivers are equally involved and equally affected by it. And they are the ones who are at times not seen. So they are a big part of this. And I, as a neurologist, always with you to kind of help with the disease journey. So brings us to the next question of treatment of Parkinson's disease. as we all know, unfortunately, there's no cure that we have discovered yet for Parkinson's disease. But there are a lot of ongoing trials, which brings us, I know a lot of you guys always ask the neurologists, what do you think of stem cell therapy? What do you think of the restorative therapy to replace or entrain your brain about it, or the alpha-synuclein monoclonal antibody research which is going on. So there are lots of research which is going on, which brings us hope. And I hope one day, before I die even, we have hope for Parkinson's disease patients, and we are able to bring something to the table which is actually indeed a disease-modifying therapy. But so far we don't. So far what we have is what we call carbidopa, levodopa, or dopamine for the treatment of Parkinson's disease patient. So this is just a brief history of for the treatment of Parkinson's disease. It goes back or dates back to 1800s with Charcot, and then levodopa was developed in 1957, and the pharmacist actually got the Nobel Prize for his work eventually in 1967. And then there are a lot of these treatment options which I've listed here, which are either dopamine or medications to increase or enhance the effect of dopamine, to make sure patients stay on medication and has less of the off periods, with the recent one being infusion therapies. So there's this Duopa pump, which is more invasive, it's a pump which goes inside your gut, or so it requires a surgery, or levodopa pump, which is a subcutaneous pump which has been FDA approved in 2024, or an apomorphine pump which was FDA approved in 2025, which both of these are subcutaneous to help reduce the off periods. So far still the treatment of choice is levodopa. It helps improve patients' symptoms of tremor, slowness, stiffness, and some walking difficulties, not the balance. Balance may or may not improve. That's something which is very tricky. So far we are still relying on dopamine for the treatment of motor symptoms of Parkinson's disease. And then the dyskinesias, the off periods, where basically it can happen on medication or off medication. Dys means abnormal, kinesia means movement, so abnormal movements, for which we use amantadine. And I will touch on the deep brain stimulator, the surgical piece in the management of Parkinson's disease in a little bit. So levodopa problem. This is a big question, and I wanted to talk about it because we are saying Parkinson's 101. So it's always about getting diagnoses, but I don't want medication. If I have to be on this medication for my life, would it be efficacious for me in future, or is it too early? As I briefed before, quality of life. Quality of life matters, and it matters today. So it's all about today, live in the moment. And it's back in the days we used to think that's a traditional approach. Patients need levodopa. Why start the patients on it today? We can just wait for it because it's gonna increase their risk of developing dyskinesias. However, what we learned from research, and there's this big African research where they didn't have the dopamine medication for some time, and those patients, compared to the other who remained on dopamine all throughout the course, we noticed that they developed dyskinesias regardless. So now we know dyskinesias can be from medication or from disease itself as well. So I'm all about giving the benefit to patient, improving their quality of life. So this is talking about on and off, on and off. So when patients go and to the doctor's appointment, they're diagnosed with Parkinson's, we start with the mainline medication, the first line medication, Sinemet, carbidopa, levodopa. However, they start noticing ups and downs. We can add some dopamine agonists or MAO inhibitors or COMT inhibitors. What are these? They are big words. They are just making sure whatever dopamine is in your body or we are giving you is lasting for longer duration. So you have more on versus less off. However, as the disease progresses, patients have more and more off periods. And then at that time, we talk about these other forms of carbidopa, levodopa, which is this big name here called Rytary. And when I start patients on Rytary and they improve, and they have less of the off periods, instead of ups and downs, high peaks, they have less. They're like, why didn't you start me on this right away? It's one of the things we start with the traditional medication because A, it works. It's not expensive, it works for patients, and it also helps us decide your dose with Rytary in future. There are now another form of which is carbidopa, levodopa, kind of similar to Rytary, which is what we call Crexont, which was FDA approved in 2023. And then another form is called Divi, which is still like Sinemet, but it has these indentations on it so that you can cut it in even quarter piece easily without just having to use the pill cutter and a teeny tiny pill. So this is the trial from Rytary, where we learned that patients don't have as much of off periods that we notice more so with carbidopa, levodopa, and Rytary gave them more on symptoms. For now, what do we have for available formulation of carbidopa, levodopa? So Sinemet, immediate release, extended release. There is this thing called Parcopa, which is more like a powder, which patients can put in their mouth. These are something which they can use when they go to the hospital, they are having surgeries or undergoing a procedure. So for short term, they can get that done. And then there are this other medication, which some of you or few of you may be on, which is what we call Stalevo. So it has entacapone in it, which is what makes sure it's lasting for a longer period of time, as I mentioned, but it's combined in one pill. And then Rytary, the Duopa pump, which I talked about, which is more invasive, goes inside your gut, and it delivers constant carbidopa, levodopa, instead of having to take oral pills, and more so used in patients who develop nausea from medications. And there is this inhaler called Inbrigia. When do I use it? I don't use it. I'm not a big fan of this. Why? Because it's an inhaler. I don't know how much it's gonna pump in one time. I use it in patients where they're freezing. I had a patient once who was traveling, who went internationally on a flight, and he was stuck in the bathroom because it's a tiny space, and he has the freezing in the bathroom. I had another patient who would always get stuck in the elevators. For those patients, I always give them for those situations so that if they are struggling and they are in these scenarios, they don't have to struggle. They can just use that has immediate delivery and helps with the freezing moments. And then, as I mentioned, the subcutaneous pump, the phos-carbo-phos-levo pump, and then which is subcutaneous pump, and then apomorphine pump as well. This is an example showing the Duopa pump on the very right, and then on the very left is the inhaler, Inbrigia. So, and then these are the enhancers for their motor symptoms. Most recent one, which is not the dopamine one, is what we call istradefylline, which helps make sure it lasts for longer. Honestly, when patients are at the point where they have more motor offs or fluctuations, what I do is I put them on the pump. Now we have this subcutaneous pump, which works really well for patients. So instead of complicating their regimen and having to deal with the side effects which can happen from these medications, I use these newer things. This brings us to this next topic of surgical treatment for Parkinson's disease. So I have this question which patients would ask me, when are we gonna do the surgery? I don't want surgery. I don't want somebody to drill a hole in my brain or burn a hole in my brain. I don't want that. I tell my patients, don't say no to things. We are going to cross that bridge when we are there. And it's a very good avenue to help with the quality of life. Why? Because when patients, as the disease progresses, so neurodegenerative disease, it progresses with time. Patients have more tremors, patients have more slowness, more stiffness, and walking difficulties. As it progresses, they need more and more of dopamine. So they are getting more dopamine so that their quality of life is better. However, then they start developing side effects from dopamine, because it's not your body making dopamine, it's what we are giving to you. So it can cause dyskinesias, the abnormal dancing movement of the body, or hallucinations, or orthostasis. What is orthostasis? The lightheadedness. Patients get up and they feel woozy, and they're falling, and they're ending up in the hospital because their blood pressure is dropping. So we know that the patients need more dopamine, but we cannot give it to them. Why? Because it's gonna cause all these side effects. So at that time, we have this great procedure which we can do, which along with dopamine, help improve their quality of life so that they're still able to travel, they are still able to work. So what do we call this thing? We call it deep brain stimulator therapy. It's a minimally invasive stereotactic surgery. It's a surgical procedure, but it's a procedure of choice for Parkinson's disease. It's still reversible. It doesn't cure your disease. It is something which does what dopamine was doing. So this is a picture depicting what I'm gonna talk about. So it's a minimally invasive procedure where the neurosurgeons drill a hole and implant the device in your brain. That's the stage 1, followed by stage 2, where they implant a battery, which is like a pacemaker, under their skin in their chest. You can feel it, but you won't be seeing it. And they connect it by a wire which goes under your skin, behind your ear, and it's connected to that lead in your brain. Patients ask me, do we feel shocks? No, it's nothing like you're walking and you're experiencing shock. When do we start talking about it? How do we decide you are a good candidate or you are not a good candidate? We'll talk on few of those and touch about it in a little bit. So who? I talk about it like this, 5 things. I'm always about a little bit pragmatic about my approach and giving more examples like that. Number 1, you need to respond to medication. Dopamine response. How can I attest you respond to medication or not? So you come to my clinic or you go to a neurologist and you didn't take the overnight dose or the morning dose of Parkinson's disease, whatever you're taking, dopamine in the form of levodopa, or Rytary, Crexont, whatever you are taking. But you bring those medication with you to the clinic. You are mostly the first patient in the clinic. They do an off medication exam, and then they do an on medication exam. You have to have 30% or more improvement on medication for them to say that you are a good DBS candidate. This brings to the question, if they don't respond to tremor, we call it tremor refractory cases. They still qualify for DBS. However, I have patients who would say, what if I don't respond to medication? Why can't I get it done? That's because you are going through a surgery. I don't want you to go to a surgical procedure, yet a brain surgery without, and then when you get it done and you're like, but it's not responding. So that's the reason why we have all these things. Sitting here saying today, or standing here saying today, you are a good candidate for DBS. It's not going to happen tomorrow. It's a very multidisciplinary approach that we work with our neurosurgeons, neuropsychologists together to help make sure you are a good candidate. You should not have any, patients should not have any red flags. What are red flags? Hallucinations, feeling lightheaded, loss of postural reflexes where you pull them and they fall on you. studies have shown after the DBS, all these symptoms get worse because they are suggestive of advanced Parkinson's disease. In advanced Parkinson's disease, it tends to make everything worse. Number 3, patient's memory has to be at a good place. There was a big trial called a control trial in early 2000, I think 2005, which talked about patients who had memory issues, significant memory issues before they got the DBS. It got worse afterwards. How can I test and say, okay, your memory is bad, you are poor, you cannot do I cannot do DBS on you, or you cannot do DBS? They have to go through neuropsych testing, which is a 4-hour-long test, and they test a few domains. Some memory issues, mild cognitive impairment is okay. It's a graph where they have to look at. If it is poor, then you are not a good candidate for DBS because it's reflective of what we talked about, advanced Parkinson's. Number 4, the neurosurgeon has to test and say, okay, you are a good surgical candidate. I have patients with high blood sugar levels or chronic heart failure, so they're not good surgical candidates. And last but not least, we do an MRI of the brain and make sure where we are gonna implant the device looks okay. So it's not just sitting here saying, I think we should start talking about DBS and it's gonna be done tomorrow. It is so that it is a multidisciplinary approach so that nothing is left behind or we don't have like loopholes. And then what are the symptoms which respond to DBS? This is so important. I cannot emphasize enough on this. Why? Because it brings patient satisfaction. Patient satisfaction. You undergo a procedure. You undergo a surgical procedure. If nobody talked to you about these things, patients are feeling disheartened afterwards. Why? Because they thought their speech is going to improve after DBS. They thought that their balance is miraculously going to be how it used to be back before, like they were developed Parkinson's disease. Or they thought they're not going to be on medication. This is a replacement for medication. So bottom line here is it responds to pretty much same things which medication respond to. It's not the replacement for the medications. It works with medication to help improve your symptoms. Freezing is so hard to be treated with medication or with DBS. If it responds to medication, hope is that it will respond to DBS as well. And then last but not least, patients always ask me what stage of Parkinson's I am on. What does it entail? How I'm going to progress. So there is a staging system which we call Hone and Yahr scale. So these are the two scientists, Hone and Yahr from New York. They came up with this scale, which is basically patients are walking by themselves, stage 1. If they are limping, stage 2. If they are using a cane, stage 3. If they're using a walker, stage 4. If you're using a wheelchair, stage 5. Does it tell me anything? Not really. Why? Because patients can use wheelchair because of multiple reasons too, right? Patients can be using a walker, but then when we give them medication, they go back to stage 2, right? So it doesn't define how you are going to progress, how many years you have still left for you. But it can depict your quality of life. It can talk about your quality at this point, which we can gauge at times, especially in situations like this. So these are the absolute contraindications for DBS, which we spoke about. And some of these are there. Why? Because sometimes patients early on look like Parkinson's disease, but they really don't have Parkinson's disease. They have Parkinson's mimic, which are bad diseases. They don't respond as much to medication. So these are built to avoid those situations or scenarios. And then, as I said, it's a multidisciplinary approach, interdisciplinary approach. It's not just a neurologist who can say, we are going to do DBS. it has to go through the neuropsychologist, the neurosurgeon, and at times a psychiatrist too, to help make sure their mood is better as well. And then the targets for DBS. What are the targets for DBS? There are two targets which we are commonly using in the brain. Are we using in the thalamus or in the globus pallidus? It depends on patient per patient. I think I have those cartoons, and that's what it's talking about. One side versus two sides, or I think I have the cartoon after this. One side or both sides. So I have a few patients who are like, but my right side is worse, and that's the only one where I have symptoms. I tell my patients, or most of the neurologists would say, your other side is also affected. It's just that one side is worse than the other. So when you're going through the surgery, let's just do it on both sides of the brain instead of just doing it on one side of the brain. Putting you through anesthesia and going all of these things done is not easy. So we normally recommend bilateral versus unilateral. And then the target is dependent on case per case. Are they awake during those procedures, or are they asleep? Back in the days, we would just do awake procedures. Patients would bring their guitars, patients would bring their sewing kits, so that we are making sure we are in the right target. Now with the technology, we can even do it asleep, and studies have shown asleep versus awake. There is no kind of changes between awake or asleep. So far, as I've been practicing since 2020. I had only one patient who opted for awake. Patients don't want to go through awake procedure anymore. So this is what I'm talking about, interventional MRI-guided DBS implantation. We have two target, SDN, and the globus pallidus interna. And I think I didn't put it in here, but that was basically talking about patient's profile. We look at the patient, and depending on patient's profile, we decide what target we are gonna use. There's never gonna be one target which is better than the other target. It depends on the patient profile. Both of these are good procedure depending on, or good targets depending on patient profile. If patient has one thing in their motor exam which is more compared to other, we depend and decide based off of their exam and their profile and how they're responding, and choose a target for them. And it's a decision which we make with the neurosurgeons to kind of like decide a target for them. There are three hardwares which are available for DBS. One is Medtronic, one is Boston Scientific, and another one is Abbott. I use all three of those, and we decide and talk about each of those and work with the neurosurgeons to help kind of like developing or choosing the target and the hardware for you. So next step, where are we headed? So patients, when they're diagnosed with the Parkinson's disease earlier, it's mostly motor symptoms that they are dealing with. And then they respond to medication, they take medication, they respond to it. But the patients are always like, do we have anything that we can trace, which can talk about how my disease is gonna progress, where I am at, how many years I have, how much quality of life I'm gonna have. This brings us to this big question for biomarkers in Parkinson's disease. What are biomarkers? Biomarkers can be used to diagnose patients with a disease or to track their progression or response to therapy as well. Like diabetes. Patients would go to the hospital, they get A1C testing. And what does A1C tells you? A1C tells you that they have diabetes, right? If it is elevated, more like, for example, if somebody's A1C is 8.1. So we said that they have diabetes. Now we give them medication, and then they come back in 3 months, and we retest their A1C. And it is coming down to 7.1. And we are like, okay, you responded to medication. It's getting better. We are heading in the right direction. But in Parkinson's disease patient, we don't have anything like that. There are ongoing trials. There are ongoing things which we can work on. But there are a lot which has been proposed and we are working on, but we still don't have anything which is available as yet. When the patients are in their mid-stage disease, it's basically the motor features, they're responding to dopamine deficits, they're doing better, and they have some non-motor symptoms, the non-motor symptoms that we talked about, constipation, sleep issues, some memory issues, and then some orthostatic hypotension, which means drop in the blood pressure, not significantly. But as the disease progresses, they have more of these non-dopamine features, which kind of like manifest. And patients, when they are diagnosed, they are always seeing all these. In this room, you see patients with Parkinson's in different stages, right? Or they have different profiles. So everybody is different, and they think about, I'm gonna be like him, or I'm gonna be like her. We have seen, I cannot tell how my patients are going to progress. I see patients with Parkinson's from morning to evening. I see almost 10, 15 patients a day, and I still cannot tell. There's no research which can tell that how you are going to progress. But as the disease progresses, the motor symptoms are here, but then the non-motor symptoms, the memory issues, the hallucinations, they dominate. And then this takes the back seat. Although it is affecting their quality back then with their walking and their motor symptoms, now these non-motor symptoms are affecting their quality. So what you can do today to help improve your quality for future. What we have learned from research, and as I tell you guys, I'm telling myself too, exercise, high intensity exercise. Studies have shown if you are exercising before you even develop Parkinson's disease, you are gonna have a better disease progression compared to those who develop it at the time, or start exercising at the time of diagnosis. So exercise, whatever you can do, develop some sort of exercise regimen for yourself. Mental and emotional health. This is a great place to have that support, to go through that mental and emotional support. Nutrition, eat healthy. Good sleep hygiene as well. And then make sure, diagnosis changes a lot. It changes your perspective about life. But it's all about, in life, it's all about perspective. That's what it is. That's what I've learned from my patients too. We all have a story. My story is very different from your story. Your Parkinson's story is different from somebody who is sitting next to you. So our hope is that your story is gonna define you, and not just the disease is defining you. And I have learned this from my patients, how Parkinson's disease, it changes your life, but there's one thing which is common, the resilience and the strength. And that's what I've always seen in my patients. And it's just universal. Whenever I meet my other movement disorder colleagues, and they are also talking about the same thing. It's the strength that they depict, which makes you go to work every day and see your patients. So as I'm really thankful to each and everybody kind of like showing the strength, and then coming here and being a part of this support group, and also telling me or teaching me things that you have taught me all along as well. Thank you.